Now today we'll be talking about a very interesting ECG. You can simply pause the video and you can try to sort key what could be the problem in this ECG. Now when we see this ECG, what we can very clearly notice, see these are the chest leads, which are basically lead 1, lead 2, lead AVR, AVL, AVF. And see these chest leads, this V1 to V6, these are chest leads because these are applied over chest. Okay, this V1, V2, V3, these are all chest leads, whereas this lead 1, 2, 3, AVR, AVF, these are all limb leads. Now, in this ECG, what we can crystal clearly see is the amplitude of this uh, QRS complexes is much, much less. You can very nicely make out in all these limb leads, this QRS amplitude is around less than 5 millimeter. This is the amplitude. It is less than 5 millimeter. If you can see, this is 1, 2, 3, 4, and 5. Here it is hardly 1 and 2. It is 1, 2, 3. Here it is 1, 2, 3, 4, and 5. Here it is 1, 2, 3, 3.5. So all these limb leads it is less than 5 millimeter, and in chest leads it is less than 10 millimeters. So you see here it is around 7 millimeter. Here it is 5 plus 2 and 1, 8 millimeter. Here it is around 5 and 4, it is around 9 millimeter. So in short, this is a low voltage ECG. When we call it as low voltage ECG, when the highest QRS complexes are less than 10 millimeter in this chest leads, and when it is less than 5 millimeter in limb leads, we call it as low voltage. Now low voltage ECG is very typical or very commonly can be seen in very few conditions, like if the patient is very obese, so heart will be automatically placed very far from the skin because he's very obese. So in between the heart and the body there will be fat, there will be muscle, there will be so many things. That is the reason why there will be low voltage. The same thing can be because of the pleural effusion, emphysema, COPD patients, again the same thing. The heart will be much placed away from the skin because of the air, because of the gases, because of the fluid, because of the fat. That is the reason there will be low voltage. Other reason why we can get this low voltage is hypokalemia. So hypokalemia is extremely common. Any patient who is getting diuresis, any patient who is very much dehydrated, any patient who has so much of urine output because of any reason, polyuria because of any reason, any patient who has very much nausea, vomiting, loose motion may definitely have hypokalemia because of the loss of potassium. So, what are the features of hypokalemia is these patients can definitely have low voltage ECG. That is very important to remember. The second and the third things are these patients have the earliest thing will be the T wave flattening. So, when we see the T wave will be flattened, the second thing will be there will be inversion of this T wave. There will be inversion of T wave. Now you see the in this HZ, we really don't have very good T wave. Here you can see something like U, but sorry, T, it is not T wave. We don't have much well T wave here. See, it is all flat. Here you see it is all flat. It is slight elevation is there, but it is almost flat everywhere. Here it is completely flat. So we actually don't have very good T wave, which should be positive. So presence of T wave flattening or T wave inversion highly suggests hypokalemia. So in this ECG, we actually don't have very good T wave. We are not able to see a positive T wave. In fact, the T wave is more of flattened. So we don't have T wave here. And as hypokalemia is severe, there will be more potassium loss. There will be T wave inversion. So you can see here that there is inversion of this T wave. There is inversion of the T wave. Here the T wave is not at all there. Here there is slightly T wave inversion. So here we don't have good T wave. Here there is T wave is all absent. So in almost all the leads there is no T wave. T wave should be there, but T wave is flat. T wave is not at all there. So low voltage ECG, flat or loss of T wave or flattening of T wave or inverted T waves is a feature of hypokalemia. The second most important thing for hypokalemia you can get is presence of U wave. Now what we get, U wave is only and only seen in T wave. It is always a wave which is carried out by, or it presents just after T wave. So in hypokalemia, we know there will be flattening or inversion of T. So it will be followed by a positive wave, which is called U wave. Now these U waves are very much well seen in anterior chest leads. So you have to see V1 to V6, especially from V3 to V6. So we can very nicely make out that this positive is actually the U wave. So this is U wave, this is S wave. Sorry, this is T wave. This T wave followed by a positive U wave. So this is a very typical example of low voltage ECG having inverted T followed by positive U. This is inverted T and positive U. So here we can very nicely make out that this is T wave followed by positive U wave. T wave followed by positive U wave. So this is U wave and this is T. This is T, this is U. Same here, this is T and this is U wave. This is T wave and this is U wave. So if you really want to understand in lead 2 also you can see this is T wave which is downgoing or negative followed by a positive U wave. Positive U wave. So low voltage ECG, a flattening of T or inverted T followed by a positive U wave, especially in lead V3 to V6 or anterior chest lead, highly suggest hypokalemia. This particular patient, the patient whose ECG is this, is had potassium of only 2.2. So whenever we want to give correction, you have to remember maximum potassium correction which can be given per day is around 8 to 10 ampules. 8 to 10 ampules, 1 ampule of Ksol or potassium usually contains 20 milli equivalent per liter of this potassium. So maximally you can give this 8 to 10 ampules per day. Other things which you need to remember, you cannot correct more than 10 milli equivalent per hour. So what mostly is commonly carried out is 2 ampule of Ksols is added into 100 ml NS and it is given at 20 ml per hour, maximally at 25 ml per hour. So you simply give 2 ampules of this Ksol over 5 hours, means you give around 8 milli equivalent per liter of Ksol every hour, and you can replace such 6 ampules, 8 ampules back to back after completing 100 ml of INS. This Ksol is extremely irritable. This injection Ksol is extremely irritable, extremely painful, irritable. That is the reason why this much of concentration cannot be given by peripheral intracath. Cannot be given by peripheral intracath. Best is to give this via central line. So with central line only, this much of Ksol can be replaced. If central line is not there, then these 2 ampules can be diluted in 500 ml NS, and this can be given at 100 ml per hour. This will be much more irritable for the blood vessels, and this 2 ampoules IV in ampoules can be given. So same 2 ampoules can be given over a period of 5 hours. We must know that this potassium deficiency is very commonly associated with magnesium deficiency as well. So whenever you are correcting a K-sol, you can give 1 ampoule of magnesium sulfate as well with this K-sol. So this was all about hypokalemia today. Thank you.